Welcome to Chapter 36, Obstetric and Gynecologic Emergencies. So a little bit of anatomy and physiology. The female external genitalia includes the labia, the perineum, and the mons pubis. In the picture there, you can kind of see it. Internal genitalia includes the vagina, the birth canal, which is a smooth muscle, the ovaries and the fallopian tubes. The ovaries are responsible for producing ova, or the egg. The fallopian tubes are where they go through and where fertilization usually occurs, and then the egg moves through the fallopian tube to the uterus to get implanted. If it doesn't get implanted into the uterus and it gets implanted into the fallopian tube, this is an ectopic pregnancy, and it's a very serious problem. The uterus, this is a muscular hollow organ located along the midline in the woman's abdomen, lower abdominal quadrants. It's the intended site for a fertilized ovum or egg to implant and develop into a fetus. The uterus can stretch and grow as the fetus gets larger. And then the cervix is a muscular ring that separates the uterus and the vagina. The cervix is where they check to see how you are dilated, and typically you're dilated to a 10 before birth occurs. The reproductive cycle, so menstruation, this is stimulated by estrogen and proestrogen. The ovaries release the ovum, and the uterus wall thickens. The fallopian tubes move the egg toward the uterus. Without this fertilization, the uterine wall will expel the egg, basically causing bleeding 3 to 5 days. Fertilization, so when the sperm reaches the ovum becomes an embryo, and that embryo implants into the uterus, and then fetal stage begins at week 8. So some physiological changes that occur. So we have changes in the reproductive system. So at 9 months, there's 9 months of pregnancy with 3-month trimesters. The placenta, which is that organ of maternal and fetal tissues, starts to begin. Exchange. It's where the area where the exchange between mom and fetus occurs. It exchanges oxygen, nutrients, and waste products. The umbilical cord circulates blood, which is expelled with delivery of the baby in the placenta. The amniotic sac is a fluid-filled sac that the fetus then floats in to cushion and maintain constant fetal body temperature. Other physiological changes, so they'll have an increased blood volume, cardiac output, and heart rate. They will have increased oxygen demand and consumption, and the GI tract is slow digestion, and they'll have some nausea and vomiting as well. Hormones will change and release, and this allows the ligaments to become more elastic, but with that they are vulnerable to injury. The additional weight affects posture, possibly leading to back pain and balance issues, and any kind of pre-existing medical conditions as well could change. Supine hypotensive syndrome, this is when the mom lies flat on her back. It compresses the inferior vena cava. All of that pregnancy weight is 20 to 24 pounds. Their cardiac output decreases. They get dizziness, and they also get a drop in blood pressure. Hence the reason that we don't put moms on their back. Labor and delivery. So stages of labor, we have 3 stages of labor. We have the first stage starts with regular contractions and ends when the cervix is fully dilated to that 10. The second stage is when the baby enters the birth canal and is born. The third stage begins after the baby is born and then ends when afterbirth is delivered. In the first stage, you can also have these Braxton Hicks contractions. They are irregular, they're not sustained, and it's not indicative of impending delivery. Basically, they are practice contractions. The body is saying, hey, I am getting ready to deliver this baby, this thing, so I'm just going to have these Braxton Hicks contractions. They'll also have some lightening. The fetal movement will move from high to low, down toward the birth canal, and then contractions of the uterus will produce normal labor pains. So characteristics of these labor pains include contraction time or duration, contraction interval, and frequency. When they last 30 seconds to 1 minute and are 2 to 3 minutes apart, delivery of that baby may be imminent. So the closer that they get together and the shorter they last is typically imminent delivery. Then they'll have this breaking of the amniotic sac. It's that sac that surrounds the baby, floats them. If there is meconium staining, meaning that baby has pooped inside the sac, it'll be like a brownish yellow type staining. This indicates that there may be fetal distress. The second stage, this is when we have full dilation of the cervix. Contractions start to increase frequently. Labor pain becomes severe. Mom feels the urge to push or move their bowels, and then we have to decide whether or not to transport the patient or keep them there. If mom feels the need to push, contractions are what they are, 1 to 2 minutes apart, 30 seconds to a minute, you're not going anywhere, and you're going to deliver that baby right there, wherever you are. So third stage, this is after baby's birth. Contractions resume until the placenta is delivered, and it usually lasts 10 to 20 minutes. It can be anywhere from up to 30 minutes after baby comes. So 30 minutes after baby is born, they can start having these contractions again, and the placenta will be delivered. Traditional patient assessment is airway, breathing, circulation, primary assessment, past medical history, and history of secondary assessment. So you also want to know expected due date, first pregnancy, has the patient been seen throughout the pregnancy by a doctor? When did labor pain start? Has the water broken? Does she have any kind of bloody show? Has the patient felt the need to push or move her bowels? And then we're going to examine for crowning. Crowning is when you see the top of the baby's head come out of the vagina, and then take any kind of vital signs. So findings that might indicate the need for neonatal resuscitation include no prior prenatal care. They may have a premature delivery. So premature is anything before 38 weeks is technically premature. Viability for newborns is about 28 weeks in the field, and then 19 weeks in the hospital. They can also have some labor induced by trauma and multiple births. History of pregnancy problems such as placenta previa or a breech presentation. If they are a breech, if they've had prenatal care and regular ultrasounds, the doc should know that they are a breech. So they should know if they're a breech. Sometimes they don't. They can also have labor induced by drug use and meconium staining. So all of these things indicate the need for neonatal resuscitation. So normal childhood or childbirth, um, we do not deliver the babies, moms do. Our primary role is basically to facilitate that delivery and to make sure that mom's taken care of and baby is taken care of if we need to. We're going to control the scene, wear proper PPE, place mom on the bed, floor, or stretcher, remove any kind of clothing obstructing the vagina, position an assistant and the OB kit, and if possible, make the environment as warm as possible. Off-duty delivery supplies, so clean sheets, towels, heavy flat twine or new shoelaces, towel or plastic bag for the placenta, clean unused rubber gloves and eyewear, and some type of head covering for the baby. Assisting the delivery, position for constant view of the vaginal opening. Be prepared for the patient to experience discomfort and pain. Provide emotional support and communicate with the patient throughout contractions. Keep someone at mom's head, typically dad, if they're there. Position your gloved hand at the vaginal opening when the baby's head starts to appear, and then you're going to place a hand on the baby's head as it bulges out to prevent a sudden uncontrolled expulsion. This isn't like baby's going to shoot across the room, but they can come out forcefully, and so we're just going to try and minimize that forcefulness that's the baby's coming out of. And then you're going to place one hand below the baby's head as it delivers to support it. Okay, so if the amniotic sac is not broken at the time of delivery, you're going to use your finger to puncture the membrane. This is called an in-caul death, E-N-C-A-U-L, birth. Did I say death? Birth. In-caul birth. This is one of those things that it sounds good to put your finger in there and puncture the membrane. However, that's probably not going to work. I've had one of these in my time, and where I assisted with the delivery to somebody else. I was not the person delivering the baby. So what we did was we took a scalpel and punctured the sac, and then we took a finger and broke open the sac and opened it more because it was not going to break with a finger. Once the head delivers, we're going to check to see if the umbilical cord is wrapped around the baby's neck. This is called a nuchal cord. The nuchal cord, if it is, we're just going to slip a finger in there and wrap our finger around the baby's head. If we can't, then we're going to clamp in 2 spots and cut. And then we're going to help deliver the baby's shoulders. Support the baby through the entire process. Assess the airway. Use a syringe to suction the mouth and nose. We have the little bulb syringes, bulb suctions in the OB kit. And this is only if baby is showing signs of distress that we're going to suction. But we don't necessarily need to suction prophylactically. Okay? And then note the exact time of birth. Ongoing assessment, so do not forget to continue assessing and care for the mother following birth. Use the primary assessment to identify any kind of life threats. Most frequent risk for the mom is bleeding, and provide emotional care. So the neonate. So when we assess the neonate, we're going to do it immediately at birth. Protocol usually calls for noting ease of breathing, heart rate, crying, movement, and skin color, or using the APGAR score. This doesn't necessarily guide resuscitation efforts because We use different criteria for that, but this does give us a good starting point. So APGAR stands for appearance, pulse, grimace, activity, and respiratory effort. Each one of these things is worth up to 2 points. So they can have a total of 10 or a total of 0. It does go, each category goes 0 to 2, and you're going to give each thing a score. So 10 is great, 0 is bad. Lots of resuscitation probably going to happen. Okay. Keep the baby warm. Heat retention is a priority. The baby cannot control their heat right now. So dry the baby, discard any kind of wet blankets, wrap them in a dry blanket. We have infant warmers on our truck. You're going to cover the head and also encourage breastfeeding. So cutting the umbilical cord is not necessarily a must, but we may need to do it. So if the cord is wrapped around the baby's neck and cannot be slipped over the baby's head, if it's attached and impedes resuscitation efforts, if attachment interferes with urgent need to transport mom or baby, and if protocol requires it. So you're going to keep the baby warm, use sterile clamps, apply 1 clamp 10 inches from the baby, apply a second clamp 7 inches from the baby, and then you're going to cut in between both of those clamps. Be careful when moving the baby so no trauma is brought to the clamped cord as well. Place the baby on the mom's abdomen and allow her to begin breastfeeding. And you want to keep, when baby first comes out, you do want to keep baby at the level of the vagina. Dry, warm, and stimulate the neonate for 30 seconds. Establish that the baby is breathing. You want to evaluate respirations and heart rate and muscle tone. If it's shallow, slow, gasping, or absent, we're going to provide positive pressure ventilation at a rate of 40 to 60 a minute. So if we need to do some resuscitation for baby, we're going to assess the infant's heart rate. If it's less than 100 beats per minute, we're going to continue positive pressure ventilations. If it's less than 60 beats per minute, we're going to begin chest compressions. At 120. So you're going to do about 90 compressions and 30 ventilations in that time. If adequate respirations and a pulse greater than 100, we're going to just move to routine care. So care after delivery, we're going to care for mom. We're going to assess risk for serious bleeding, infection, and emboli. Deliver the placenta and control any kind of vaginal bleeding. And then comfort mom. When we deliver the placenta, this is after birth. That includes the placenta, the umbilical cord, the amniotic sac, membranes, and the tissue lining of the uterus. Placental delivery starts with labor pains. It can take up to 30 minutes or longer, and then we're going to just transport in 20 minutes. If there is vaginal bleeding after birth, we're going to place a sanitary napkin over mom's vaginal opening. Do not place anything in the vagina. Have mom lower her legs and keep but not squeeze them together. Massage the uterus with a fundal massage. It is not quite like that. It is more using a fist into the fundal, the fundus of the abdomen, and you're gonna just start going to town, massaging it. Encourage mom to begin nursing the baby as well. When mom nurses, it releases Pitocin, which is a contraction hormone. So if mom starts to have bleeding, they can nurse and release that Pitocin. Take vital signs frequently. Acts of kindness will be appreciated and remembered. Wipe their face and hands with a damp washcloth and replace any kind of blood-soaked sheets and blankets. So complications of delivery. Common complications are cord around the neck, um, unbroken amniotic sac, and infants who need encouragement to breathe. They may also have a breech presentation. This is the most common for an abnormal delivery. Buttocks or both legs may deliver first. The risk of birth trauma to the baby is high, and meconium staining often occurs as well. With a breech presentation, we're going to initiate rapid transport. This is a delivered thing that we can do in the field. If both limbs are present, both legs, we can deliver this in the field. We just don't want to pull on the legs. We're going to provide high flow O2 to mom, place mom in a head down position with the pelvis elevated. If the body delivers, we're going to support it to prevent explosive delivery, and then care for baby cord, everything as a normal delivery. Okay, limb presentation. So a limb of an infant that protrudes from the vagina. This is not an option that can be delivered in the field. So we need to do rapid transport, because if we don't, mom and baby are going to go into distress. Head up, head down, pelvis elevated. Do not pull on the limb or replace the limb into the vagina. Do not place a gloved hand into the vagina unless there's a prolapsed cord, which we'll talk about here in a minute. And administer high flow O2 to mom and notify the receiving facility. Prolapsed cords. So this is when the umbilical cord presents first and becomes squeezed between the vaginal wall and the baby's head. Oxygen supply to the baby may be totally interrupted, causing a life-threatening condition. You are going to place mom in a head down, pelvis raised position, provide mom with high flow O2, check the cord for pulses, and wrap the exposed cord. If the cord has a pulse, we're just going to wrap it in a moist, sterile dressing and leave it, checking it frequently to make sure that it continues to have a pulse. Insert your fingers into the vagina if it does not have a pulse. We're going to do this. Push up on the baby's head or buttocks to keep the pressure off the cord. Keep mom, child, and EMT as a unit, so you get to ride on the cot with the patient into the hospital, and you are stuck there until mom has a C-section. Multiple births, we're going to have appropriate resources. So if we need to, we're going to basically have more ambulances come if we need them. And then we're going to clamp or tie the cord of the first baby, assist in delivery of the second baby, and do all the placenta and cord care the same as a single delivery. Now, there may be one placenta, there may be two placentas. Just kind of depends on how the baby is. Keep baby warm, keep airway clear, provide ventilations and or chest compressions, watch umbilical cord for bleeding, and avoid contamination, and then call ahead to the ER. Meconium staining. This is a stain that stains the amniotic fluid greenish or brownish yellow. Do not stimulate the infant before suctioning. Maintain an open airway, provide ventilations and or chest compressions, and transport as soon as possible. So some emergencies in pregnancy. We have excessive pre-birth bleeding, ectopic pregnancy where the egg gets implanted and fertilizes into the fallopian tube. They can have seizures, For like eclampsia, they may have a miscarriage or traumatic abortion. They may have some type of trauma in pregnancy. They may have a stillbirth, and they may also have cardiac arrest. In the case of cardiac arrest, we're just going to treat like we would anything else. We're going to keep pumping until we get to the hospital so that they can do an emergency C-section. Excessive pre-birth bleeding can usually be caused by two things. So placenta previa, which is where the placenta blocks the birth canal. If that placenta is damaged or torn, severe bleeding can occur. And an abruptio placenta, which is where the placenta prematurely separates from the uterine wall. It is usually caused by trauma. Complete abruption causes massive hemorrhage and is usually fatal to the fetus. Main sign is profuse bleeding, abdominal pain, assess for signs of shock, provide high flow O2, place a sanitary napkin over the vagina, and save any and all tissue that has passed. Ectopic pregnancies, again, where the egg implants into the fallopian tube. It can cause acute abdominal pain, often on one side, vaginal bleeding, rapid and weak pulse, low blood pressure, and an absent menstrual period. Seizures. So seizures is usually existing. They'll have some type of existing preeclampsia where they have an elevated blood pressure, excessive weight gain. They'll have abnormal swelling to the face, ankles, and hands and feet. They may also have altered mental status, headache, or unusual neurologic findings. If your patient is preeclamptic, they're going to know that they are if they are regularly seeing a doctor. And seizures in pregnancy, the difference between preeclampsia and eclampsia is seizures. Miscarriage and abortion, so spontaneous or induced, can cause cramping and abdominal pain. Bleeding can range from moderate to severe, and noticeable discharge of tissue and blood from the vagina. Obtain vital signs. If shock is present, keep the patient warm and prevent any kind of hypoxia. Place a sanitary napkin. Transport. Save all blood-soaked pads and expelled tissues, and provide emotional support. If mom has some type of trauma, pregnant patients' pulse is usually 10 to 15 beats per minute faster than non-pregnant women. So their heart rate's going to be about 110 to 115, or let's say 75 to 110. So it's going to be that normal range. Blood loss may be 30 to 35% before signs and symptoms appear, and ask if the patient has received any kind of blow to the abdomen. Stillbirth, so we're not going to resuscitate if the baby has obviously died sometime before birth. Provide full resuscitation measures if the baby is born in pulmonary or cardiac arrest, and provide life support. Provide emotional support to the family as well. Cardiac arrest of the pregnant woman, so there is a chance to save the unborn child. We're going to begin CPR immediately. Displace the uterus if they're more than 20 weeks. Position 1 to 2 hands higher on the sternum to make up for shifting of the heart by the large uterus, and continue CPR until a C-section can be performed, or you are relieved by the ER. Alright, so gynecological emergencies. So vaginal bleeding, we're going to treat as potentially life-threatening, check for associated abdominal pain, and monitor for any kind of hypovolemic shock. This typically, when it becomes life-threatening, is when it's more than normal from a period, or they haven't had their period yet. They're in the 28-day time frame of in between periods. Trauma to the external genitalia. So when sizing up the scene, observe for any kind of mechanisms of injury. During your primary assessment, look for signs of severe blood loss and shock, and consider internal injuries as well. If there is some type of sexual abuse, we're not going to check the vagina unless we have to control some type of vaginal bleeding. Okay, so treat immediate life threats, examine genitals only if severe bleeding is present, discourage bathing, voiding, or cleansing wounds, and fulfill mandated reporting requirements. Typically, what I like to do with assault cases, male or female or kid or whatever, is I will burrito them. So I'll take my sheet, lay it all the way flat out on the cot, and then burrito them. So that way, if there is evidence on the patient, then it will stay within that sheet. And then that sheet gets placed into a paper bag when they get to the ER. All right. So any questions, let me know, and I will answer them as best I can.